Yeah, I remember the Black Hanifa. Uh, it's knowing your patients the day before. By the way, he's a singer type of like, oops, and it's quite a stressful time to intubate a singer. Anyway, I am an anesthesiologist here working in my hospital, Chancellor Tunku Mukhris, and one of the lecturers. Today I'll be going through a bit of the anesthesia part of when you guys post airway case. All right, this will be the table of contents that I'll be touching through. So laryngeal surgeries, I guess you all know more than me, affects all age groups, and the time that when they are present to us, usually is some. If it's hoarseness of voice, it's okay, but if it's involving breathing, shortness of breath, then it's entirely another thing that we have to be wary of. This, I think you guys will be know more than me. So when you post a laryngeal case or airway case, what are the things that first run through our mind? This will be our standard postgraduate questions and answer. So the concerns will be always, it's a shared airway. How do we secure the airway? Because the patient's head is always away, it's far from you and you cannot reach the airway immediately. And how do you want to ventilate the patient? Provide oxygen, remove the CO2. And yet you have to provide a surgical field for the surgeons to do their work. So that is always a challenge. And how do you want to maintain the anesthesia? How do you want to keep the patient unconscious, either from your inhalational gases or from your IV agents? So the pre-operative evaluation is actually very important. Pre-morbidly, you need to know the medical issues because the patients who present usually are elderly and they have smoking-related illnesses, and they probably have some cardiovascular illnesses that makes their cardiovascularly reserves are not that much. And we always have to take detailed history and go to a proper physical examinations. The thing that you want to know will be, is there a difficult airway? So in any situations, will it be difficult to put a tube in? If it's not a difficult airway, then okay, you're a bit relieved. But of course, you have to deal with what is the procedure and how do you want to secure the airway. And same goes for the neck mobility, and also you have to review all the investigations. Typically, what I like to look at will be the nasoendoscope videos that usually we will be asking like, hey, can you share the video from your clinic? So that will be, in the sense, give you a warning or give you an idea of what is the airway is going to be. Some pictures that airway surgery is always very happening, very a lot of people in OTs. Yeah, even this, back in the COVID time and every year. So the anesthetic technique, mainly you go for tube or tubeless. So tube, there will be the endotracheal tube or your supraglottic airway devices that you can put into the patient and you can ventilate through ventilator. Other techniques will be like spontaneous ventilation, intermittent apnea technique, apneic oxygenation or jet ventilation, which I'll be going through later. So for every cases, for airway surgery, it will be good to have to know the fasting time. And if the fasting time is not enough, you probably want to consider prokinetic agents. You want to put in an NG tube to reduce the risk of aspiration. You probably can give some drying agents like atropine or glycopyrrolate before the operations to dry the secretions, and also appropriate equipment and the airway adjuncts that you'll be needing. I'll be going through on the types of anesthesia that we can give. We have inhalation anesthesia, that you see that the gas, that what we call usually is the gas, sevoflurane or desflurane. To induce, usually we use sevoflurane in 100% oxygen with addition of nitrous oxide. Once we let the patient inhale, they will be spontaneously breathing and they control their own minute ventilation. You have to monitor the MAC, which is the minimum alveolar concentration that sort of gives you the depth of the anesthesia that the patient is having. Of course, with narrowing or obstruction condition, the induction will be slower. Of course, this inhalational gases harms the environment, destroys the ozone. If you see that if you can con the child, scam the child very nicely, they usually will be able to induce themselves. The first thing is pre-operative visit is very important, and you have to build a very good rapport with them. And most of the time, they will be able to be conned. So the other technique of instead of using inhalational will be TIVA. It is total intravenous anesthesia, where all our agents are given through IV. So we skip the gases that I mentioned earlier. We only provide patient with oxygen, ventilations, and the anesthesia will be delivered through IV, what we call a target control infusion, with specific machines that we enter the patient's gender, weight, height, and it will calculate by how many mic or how many nanogram per mil of the agents that it is calculated. So you kept the patient sedated or anesthetized, and with that usually you see that we put in a depth of anesthesia monitor, or we call it a BIS. So usually if you are lucky, when the surgeon says, okay, you can put in a MLT tube, then you're like, okay, all right, it's gonna be a sitting down and easy job. So MLT is microlaryngeal tube. It's actually a pediatric size ETT that is long. It comes in 4, 5, and 6 mm internal diameter. It has low pressure, high volume cuff, and you just put the cuff down to the vocal cord, and the tube will actually lies between the arytenoid cartilage. So it will be leaving a lot of space for the surgeons to have a obscured glottic. Alright, so the MLT is also called a massively long tube. Oh, just kidding. And it is its advantages is it protects the airway. It's something that we do normally, just intubate the patient. You can control the ventilation, control the airway. There's minimum pollution if you use inhalational, and you can monitor the ET CO2. The disadvantage is it still obstructs some or 1/3 of the larynx. You need high inflation pressure to ventilate because the tube is small, and higher resistance, meaning that you have to actually higher pressure to ventilate the patients. And the tube can also cause damage to your vocal cords during intubation. It's always a fire, a laser airway fire hazards. So yeah, I will skip that. Laser resistance ETT is something that I add on this year because I think the last 1-2 years we've been starting using a lot of blue lasers. So we have this special type of ETT that is resistance to laser and can reduce risk of airway fire. It comes with 2 cuffs. Those 2 cuffs is 2 cuffs where you have a proximal cuff that is a backup cuff. So traditionally, we are taught that you fill both cuffs with saline, the proximal one with methylene blue, so that just in case when you puncture the cuff, you see that the blue saline is on the patient's larynx. Of course, when you are doing the laser, you tail down the FiO2 to the lowest to prevent fire. Newer things now will be supraglottic airway devices. Traditionally, it is a non-intubating or non-invasive method of securing the airway. It allows the ventilation, oxygenation, and administration of your anesthetic gases. And you can visualize the whole larynx if you put in your fiber optic scope. You can allow for dynamic airway assessment. So certain procedure like a biopsy can be performed using flexible scopes, and especially voice implant that not really internally that you're doing the operation, you're doing it from outside, but you still need to see the larynx from inside. So this is a good method, but of course the airway is not secure. The patient can still aspirate with this supraglottic device. Non-intubating technique will be a bit of like a cowboy's method. What you do is you let the patient have spontaneous ventilation with inhalational induction most of the time. You can assess the dynamic and functional assessment during that spontaneous infiltration. And most of the time here we topicalize the airway with local before we pass the airway to the surgeon. So it preserves negative intrathoracic pressure, especially if the patient has some degree of obstruction. And we insufflate oxygen and pass over, and once the patient, the surgeon done the surgery, pass back. Of course, the method is probably not suitable for patients who are having a low functional cardiac or respiratory reserve. Intermittent apneic technique will be similar, but the patients are paralyzed, and you hand over the airway to the surgeons once it's adequately ventilated. So it is a fully apneic tubeless method that has a motionless surgical field for the surgeon. But it is limited to patients who can tolerate and sustain apneic period, and you need constant vigilant monitoring. We use this usually during tracheal dilatation, that you just pass the airway, wait until that 2-3 minutes, and hopefully before the patient descends, you take back and you ventilate. Disadvantage is limited surgical time, risk of aspiration, potential trauma through multiple intubation, re-intubation, extubation. Apneic oxygenation is some sort of like a paradoxical term. You want to oxygenate the patient, yet the patient is apneic. And it's just meaning that patient is not breathing. So the oxygenation is done without any patients or ventilator moving the lung. What we do is a high flow nasal cannula with oxygen insufflation. We have that set, which is I think readily available. It's quite common in the COVID era. It aims to delay arterial oxygen desaturation, and the gas that is provided is warmed and humidified. So it is better for the mucociliary clearance. There are quite a few reports on that. That is, to me, probably I would prefer a jet ventilation kind of surgery, because that will apneic oxygenation, you would depend on the patients who have a bit of spontaneous breathing. Where else, if it's jet vent, it's more of we are in control and when you want to do your thing. So, but of course, when you're doing an apneic oxygenation, you need patients who have a patent upper airway. If it's obstructed, there's no point. And there's no CO2 monitoring. And sometimes the nitrogen wash out, and rapid alveolar oxygen absorptions can lead to alveolar collapse and atelectasis. What I usually do, what I call is my own DIY apneic oxygenation, is when you have your scope in, and when the surgeon is, while they are doing the jet ventilation or in between, I would actually close my APF valve. I redirect all 15 liters of oxygen through the suspended laryngoscope, and is sort of a apneic oxygenation. But of course, the true apneic oxygenation, the minimum flow that they use is about 30 to 60 liters. So my GA machine can probably go higher to 15. Something similar, but especially personally, I use this method for pediatric patients where you don't really paralyze them fully, and you just bang a bit with opioids, usually fentanyl, and they have a bit of respiration, and yet they are not too vigorous breathing. So usually with that, you can sustain a good 3 to 5 minutes surgical time. Jet ventilation is probably what we usually have heard of. It started by this Douglas Sanders in 1967. It's high pressure oxygen at 4 bars delivered through a nozzle placed supraglottically. The nozzle needs to be aligned along with the axis of airway to be effective. Provides a tubeless surgical field. What it does is entrain the oxygen into the larynx, and expiration is totally dependent on passive lung and chest wall recoil. So I think we are quite familiar with this MenuJet. And what we usually do in OT is low frequency manually controlled jet ventilation. We provide 8 to 12 breaths per minute of ventilation. It's usually have a fully tubeless surgical field for the surgeons. And we have to maintain the airway patency while the operation is being done. And of course, you have to be careful of what is the surgeon doing, because if not, you'll be ending up blowing your whatever gauze or whatever inside. There is also something called high frequency jet ventilation, where a machine is used to deliver 1 to 10 hertz of respiration to the patient. And this you set like driving pressure, frequency, inspiratory time, composition of the gas that you want. And it's usually has alarm and has some safety features that automatically shuts down if the airway becomes too high pressure. So this is roughly the graph. This is what we usually do. This is the high frequency jet ventilation. And of course, there are a lot of ways, and if you top up your the high flow nasal cannula with your jet ventilation, you'll get higher pressure. What we usually do is supraglottic jet ventilation, and the set was connected to a nozzle that is clipped to the suspended laryngoscope. So you have to directly observe the chest wall movement, its passive expiration, and you have to listen to the rest to know that your jet ventilation is going in. Usually there is the resonant sounds that you can hear. So short video.
Stop dua sikit. Make sure dia tak skop video. Tak skop video kan. Okay. Okay, eject more. 1, 6. Okay. Nanti 1 apa? 1, 6. Nanti 1. 7.
Alright, so while you're doing this, there's actually no CO2 for you to monitor. I think we had a case of Prof. Marina, COVID time, COVID swab negative, we are jetting to glory, and after that, patient is AFP positive. Okay, so that was supraglottic airway device. Then this is something called... I was standing far away. So transglottic jet ventilation, it is just that the ventilation is done below the glottic. So it minimizes the vocal cord displacement, and if there's blood and debris, it will actually fly upwards because you are jetting through down. And there's minimum entrainment of air, so your FiO2 is consistent. This is an example will be something called Hansaker Mon jet tube. Personally, I have not used this. It's technically, it's not really a tubeless technique, but the tube has a distal basket that once placed inside the trachea, it will position and maintain the tube to be centrally. So when you jet ventilation, it goes straight directly down the glottic. All right, and there is the modification that you can actually monitor the CO2 with this tube. And of course, there is something called transtracheal jet ventilation. Usually that is in emergency situation where you have performed a cricothyroid puncture through a cannula. So it is a poor laryngoscopic access, and usually you have some upper airway, whatever obstruction above. So comparing the jet ventilations, if you see the ventilations, the complications are barotrauma, a lot of pneumothorax, gastric distension, gastric rupture can happen from all this jet ventilation. And comparing all the methods of transtracheal, transglottic tube, mechanical tube, the complication, you can see that if you put in a tube, that's the safest for patient. If you're doing the transtracheal, you have the highest complication. This is from a study, I think, of 1,000 plus patients done in 2006. So what are the precautions? When the surgeons are hanging the larynx, be careful of the neck position, the teeth, oral structures, eye protection has to be there. Laryngeal surgery is a very intense stimulation kind of surgery. It's not really painful, but once you hang the airway, a lot of times we see bradycardia, sinus pause. So you need to have a rapid adjustment of your anesthesia depth. Be careful of ETT displacement, king ETT, because if you are using MLTs, they are very small and thin. In laser surgery, be careful of airway fire. There is the CO2 laser and your KPT and blue laser, which is slightly different. So potential for endotracheal explosion is there. Facial burn, mucosal burn, vocal cord web, vocal fold webs, stenosis can happen. That is where we use the ETT resistance, laser resistance ETT. And all staff members should be familiar with the safety precautions while you are doing a laser. Dexamethasone is something very important. If Prof. Marina post case today, you give us Dexa yesterday. So, because why? Any swelling edema, it will actually obstruct the airway, especially children, because based on the law that we don't know how to read is Poisson's law. Your diameter of the radius is the one that times to the power of 4. So any swelling to your airway or trachea in the children will obstruct the airway tremendously. Post-operative care, usually it's a mild pain kind of surgery. You can settle with non-opioids, some local infiltrate. If you have paralyzed the patient, make sure you reverse the muscle relaxant, either with sugammadex, atropine, neostigmine. Extubation has to be done prop up, awake, usually with remifentanil on board so that the patient don't cough. You apply some pressure support, PEEP, and leak test before you take out the tube. And probably you can monitor the patients post-operatively for respiratory difficulty, stridor, or hoarseness. So the take-home message is, I think you have to have clear communications with your anesthetist, what you're going to do. Know your equipment, know the patient's reserve and limits, and have a plan, but always have a backup plan. If this fails, what is the next step? Beware of the pitfall, it's always a team effort. So you can see that airway, laser surgeries is always a lot of people. So this is where I let my team do the work. It's teamwork. All right, I think that it's all.